This program is brought to you by Emory University.
Happy holidays to everybody. Welcome to our last Friday morning Fellows Conference of the year. Journal Club, our speakers this morning are Dr. Godley Jack and Dr. Mariem Sawan. Godley's going to start us off. Dr. Jack did his undergraduate studies in medical school at the University of Maryland, his internal medicine residency training at the University of North Carolina, and is currently a third-year fellow in our clinical track. And will be headed back to University of Maryland for his interventional cardiology training next year. He's going to talk to us about a study that came out recently on a subset of patients undergoing transcatheter mitral valve repair. Godley, take it away.
All right. Good morning, everyone. My name is Godley Jack, as Dr. Williams said. I'm a third-year cardiology fellow here at Emory. And today, my journal presentation is going to be on a paper that I thought was interesting. And it's titled Transcatheter Mitral Valve Repair in Patients with Atrial Functional Mitral Regurg. And I chose this topic because atrial functional MR is one that I was less familiar with. I think it's somewhat of a newer topic. And I thought it would be interesting to research that topic, learn a little bit more about it, and then come back and present what I've learned to you all. So that the general structure of this talk is that I'm going to talk a little bit about the mitral valve and how it can go wrong. I'm going to talk about this subset of atrial functional MR, and then I'm going to talk about how this study kind of tried to differentiate it from the traditional type, if I could say. So adequate mitral valve closure is really a coordinated effort, and it's going to take healthy, a normal-sized mitral annulus, healthy mitral valve leaflets, a normal-sized left atrium, a normal-sized left ventricle with normal systolic function, and those things really comprise a normal mitral valve apparatus geometry. In addition, you're going to need normal diastolic function, and last but not least, a nice, succinct, coordinated electrical conduction down your myocardium to help all those things work in a nice synchronized fashion. And these things are going to be what helps the mitral valve close in a nice way to prevent MR. But as we see in many of our patients with structural heart disease, abnormalities in any one of those things can cause significant MR. Mitral valve transcatheter edge-to-edge repair, or the mitral clip, has been established as an effective treatment strategy for patients with clinically significant symptomatic MR despite optimized medical treatment. And I would like to talk very briefly about Carpentier's classification, because it's going to be important when it comes to our methodology. So there are 4 classes, and type 1 is going to be patients with leaflet motion that is normal, but annular dilatation or perforation with the MR jet usually being central. Type 2 is going to be where we see excessive leaflet motion, flail, prolapse, billowing leaflet pathology, and the jet is going to be away from the diseased leaflet. Type 3A, type 3 is going to be restricted leaflet motion, with A being structural damage to the valve, often rheumatic, causing restricted motion in systole and diastole, whereas type 3B is restriction in systole only, most commonly associated with functional or ischemic MR. And again, I bring this up because type 1 is going to be the type that we include in our methodology. Now, more than 84% of patients present with functional MR as a consequence of LV, primarily LV pathology. So a sick, dilated LV with a decreased EF is going to stretch your mitral annulus, cause inadequate coaptation of your leaflet tips, and cause a significant MR jet leading to symptoms. The type we're going to talk about today is a little bit different, and it's named atrial functional mitral regurgitation. And the pathophysiology is that Most commonly, atrial fibrillation and atrial flutter and/or diastolic dysfunction cause progressive dilatation of the left atrium that stretches the mitral annulus. And these cases are gonna, how we define this is what we're going to add is that the left ventricle is actually going to have a normal systolic function and most commonly a normal size. This study took things one step further and looked at RV dysfunction. So there are two registries that recently showed that patients undergoing MitraClip who had RV dysfunction, as determined by RVPA uncoupling, which I'll talk about in more detail. Patients undergoing MitraClip with RV dysfunction had worse outcomes. And so the authors of this article sought to look at whether that was also true in atrial functional MR. So the purpose of this article was twofold. It was to evaluate baseline characteristics and outcomes of atrial functional MR patients undergoing MitraClip, and to analyze the prognostic impact of RV dysfunction on survival in this subset. So here is our methodology and our breakdown. We took, the patients were selected from the Euro SMR, or the European Registry of Transcatheter Repair for secondary mitral regurgitation. And these patients came from Germany, Italy, France, and Switzerland. And there was a total of a little over 1,600 patients. And first, the first branch point, we subdivided into normal and abnormal EF. So patients with reduced EF, the cutoff was 50%. So patients with undergoing MitraClip with the EF less than 50% were the ventricular functional MR patients, just over 1,300. Patients with a normal EF comprised the other two groups. You were characterized as atrial functional MR, this is important, atrial functional MR, if you had Carpentier's type 1 leaflet motion and no regional wall motion abnormalities, okay, and a dilated left atrium. If you didn't have one of those three, you were essentially non-atrial functional MR. And this is kind of like the, I wouldn't say the garbage category, but I think this was really their best effort to create a control group, which we'll talk about later. So how did they measure RV dysfunction? This was something new that I learned. So they looked at RVPA coupling, and the essential concept is that a healthy right ventricle should increase its contractility or increase its systolic function in the presence of an increasing afterload. So if my pre-A pressure goes up, my RV contractility, if adequate, should increase my RV contraction as well. So to look at the relationship between RV contractility and PA pressure, they use echocardiographic parameters, specifically the ratio of the TAPSE to the systolic PA pressure as the way we typically estimate with by echocardiography. And a ratio of less than 0.341 was considered abnormal. And again, they used the same methodology that was used in other patients to analyze RV dysfunction in these groups, in patients undergoing MitraClip. So table 1 outlines the baseline characteristics in our three groups. And from left to right, again, we have atrial functional MR group, the non-atrial functional MR group, which was, again, patients with a normal EF who just didn't qualify as atrial functional MR. And then we have the ventricular functional MR group, which is patients with reduced EF. And the major takeaway from this table was that patients with atrial functional MR tended to be older and smaller. Specifically, they had lower height, weight, and BMI. Atrial functional MR patients were less likely to be male. And atrial functional MR patients had a better Euro score as compared to ventricular functional MR, but worse compared to non-atrial functional MR. There was no difference across the board in renal function, and atrial functional MR patients generally had a lower NYHA scale class than ventricular functional MR. They were less likely to be diabetics, less likely to have previous PCI, and less likely to have previous CRT. They also had a lower BNP. I don't know if you can see it. Yeah, they had a lower BNP on average. And interestingly, atrial functional MR patients were more likely to have hypertension and for some reason had a lower 6-minute walk distance. Now, I highlight near the bottom, the most important parameter we saw was that 99% of patients with atrial functional MR had underlying conduction atrial pathology, or either atrial fibrillation or atrial flutter. And again, that gets at the underlying mechanism, which is AFib and aflutter causing dilatation of the left atrium. Table 2 tries to dissect the baseline echocardiographic characteristics of this subset. And I kind of group these into chunks. The first kind of chunk, basically, if I could summarize, is telling us that patients with ventricular MR had sicker LVs, which we know. So patients with ventricular MR had a significantly lower EF. Again, that's because that's how we divided these groups in the first place. They had a lower EF. They had more dilated chamber. So a higher left ventricular end diastolic volume, a higher left ventricular end systolic volume, and higher left atrial volumes as well. Patients with ventricular functional MR had worse MR on average as measured by the grading. So there were more that had 4+, and they had a higher, with ventricular, they had a higher ERO. Now, interestingly, if you look at the asterisk, the red asterisk, for some reason, the atrial functional MR had a bigger biplane vena contracted, which is not really consistent with what's up here as far as the MR grade. Lastly, what I wanted to pull away from this was that patients with ventricular functional MR had sicker RVs as well. As you can see, the more dilated RVs, the RV end diastolic area and the RV end systolic area was higher in patients with ventricular MR. Table 3 was important. So this table is looking at the Cox regression model for 2-year all-cause mortality in atrial functional MR. We're looking at mortality in within our subgroup. And we're looking for independent risk factors of mortality within the subgroup of patients with atrial functional MR. And what they found was that patients with an NYHA functional class 4 or patients with the presence of RVPA uncoupling had significantly worse mortality within our subgroup. So I'll say that again in a slightly different way. So of all the patients with atrial functional MR, the people who had worse mortality were the people with worse NYHA class or NYHA 4 and patients with RV dysfunction. And the hazard ratio was greater than 3 in both cases. And that's both univariable and multivariable. Now, why is this important? We'll see soon. Baseline characteristics of these, again, of our subset. The study grouped, they subdivided our subset into patients with normal RV function and RV dysfunction. And again, we're using the RV to PA ratio, looking at RV contractility the TAPC to the PA systolic pressure as measured by echo. And patients in our subgroup with sicker RVs had a higher Euro score. And the Euro score is a preoperative risk assessment from Europe, obviously, that's based on the presence of chronic pulmonary disease, extracardiac arteriopathy, age, gender, mobility, previous cardiac surgery, active endocarditis, and a critical preoperative state and renal function. So whereas none of the other characteristics in this chart were significant, the Euro score was clinically significant, and it was worse in patients with RV dysfunction. This figure looks at the 2-year survival across the board. So interestingly enough, despite the differences in the baseline characteristics that we saw before, despite the differences in the echocardiographic characteristics, and despite the difference in the Euro score across our 3 groups, there was no difference across the board in 2-year survival. Now, you could argue a 2-year survival post-mitral clip, and you could argue that this is not a long enough follow-up period, which is a fair argument. But again, there's no difference across the board with atrial functional MR, non-atrial functional MR, and ventricular functional MR when it comes to 2-year survival. This is our central illustration that really ties it all together, and moving from left to right, we kind of have the most important points from this journal article. First is that the prevalence, the first chart, the pie chart on the left is really depicting the presence of atrial functional MR. And again, it's about 8%. It was 7.8% in this study, and non-atrial functional MR was another 8%. But the vast majority of functional MR is ventricular, and that's 84%. And those are people with, again, an EF of less than 50%. I haven't touched on this yet, but the study did show that patients with MR, the MR severity significantly improved, MitraClip significantly improved MR severity and NYHA functional class in atrial functional MR. And that was important because we wanted to show that MitraClip worked in this subset of patients. So whether your MR is atrially driven or ventricularly driven, you actually benefited, you benefited from the MitraClip regardless. And I think they did touch on the benefit in both, and the benefit was just as good. The benefit of MitraClip was just as good in atrial MR as compared to ventricular MR. And then last but not least, the 2-year survival curve. Again, there was, the 2-year survival curve in patients with RV dysfunction, the survival was worse amongst patients with atrial functional MR. I want to summarize the major discussion points. So first, atrial functional MR is a subset of symptomatic functional MR patients, okay, undergoing MitraClip in this European study, and they comprise about 8% of functional MR cases. Atrial functional MR is characterized by a normal EF, otherwise normal mitral leaflets, again, that Carpentier class 1, and is almost always going to be associated with the presence of AFib and A flutter, and a dilated left atrium. And I forgot to mention diastolic dysfunction is common as well. Patients with atrial functional MR show significant reduction in their NYHA functional class and in their MR severity at follow-up at 2 years after MitraClip. So MitraClip works in this patient subset. And despite the differences in the baseline clinical and echocardiographic characteristics, the survival and clinical outcomes after MitraClip did not differ between atrial and non-atrial FMR patients. And I forgot to include the ventricular MR patients, suggesting that FMR patients with preserved EF may generally exhibit the same benefit. Multivariate analysis did indicate that in patients with atrial functional MR, the presence of RV dysfunction and NYHA class 4 were independent risk factors for higher 2-year all-cause mortality. Major limitation was that one was that there was a lack of untreated. Really, there was a lack of a true control group, and this was a retrospective study. That's the end of my presentation, and I want to thank you all for your time.
Thank you, Godley. Interesting article. You're right. I guess as I think about this, like, why sort of the why they would look at this group in particular. I suppose it's because it's a group older with normal mitral leaflets that normally wouldn't go for, surgical repair replacement of their mitral valve. If it's not a group that's developing or has a dilated ventricle or other reasons for surgery, et cetera. So I guess that's probably part of the point is maybe somewhat of a neglected group that they're trying to say, hey, fixing their valve, even if they don't have structural valve abnormalities or systolic heart failure, still may be beneficial in terms of symptom reduction. Is that your thought, is sort of getting behind why this particular sort of somewhat unusual subset or uncommon subset for severe mitral regurgitation?
Yeah, I agree. So I think when going over, I think the underlying physiology being so different from, I think what we see as, if I could label it as traditional MR, where you have a stiff left ventricle, a sick left ventricle. I think it leads to the question of, do these patients actually benefit? And the article actually starts off by saying, because we're seeing good outcomes with MitraClip, and because we're seeing this aging population with a higher presence of AFib, higher presence of A-flutter, or I should say prevalence of AFib, A-flutter, and diastolic dysfunction, it's going to be more and more important to characterize our different treatment strategies, our treatment strategies, both surgical and interventional, for this disease, to make sure we actually know what we're doing and that we're treating the right patients.
Other questions from the group?
Yeah, I just, thank you, Godley. I think you did a great job on this. To Robbie's point and to Godley's point, no one knows what to do with these patients. We see a lot of people, even in people that aren't particularly old, the atrial functional MR, I have discussions with my calcos all the time, like, should they take them for surgery? Should they not take them for surgery? And this is an area that's totally outside the guidelines in terms of, giving any sort of instruction as to what to do. So we see these patients a lot. Like you said, they're all exactly the same profile that you had. They're older women with AFib, they're tiny, and they have these tiny little ventricles, and we put clips on and we don't know if they're getting benefit from these or not, but it's certainly a very common problem. And the last thing I think it's helpful for is just for cardiologists, kind of recognizing the different types of functional, MR. I've had attendings tell me that, this person doesn't have functional MR because they have a normal EF, but that's not true. So I think that as a whole, cardiologists have a long way to go in terms of like kind of understanding the different forms. So I think things like this are great. So good job.
Thank you.
All right, any other questions from the group? All right, well, good deal. Well, thank you, Godley, for that presentation. Our next presenter, as you can see, is Mariem Sawan. Mariem is a fourth-year fellow in her final year in our basic science research track. She went to medical school in Saudi Arabia, came to the United States and did her internal medicine residency also at the University of Maryland. So some University of Maryland ties today, and did basic science research in Dr. Taylor's lab, and will be doing interventional cardiology fellowship as well next year. So She's going to talk to us. Oh, I forgot the name of this study. Mariem, what was the name of the study again?
It's Bright 4.
That's right. All right. Take it away, Mariem.
Thank you. Good morning, everyone. So I'm going to be talking about Bivalirudin in patients with ST segment elevation myocardial infarction. And so it was published just last month in the Lancet and was presented in the AHA of this year. It's a randomized, open label randomized clinical trial. I have no financial disclosures. But before I start talking about the trial, I wanted to briefly go over Bivalirudin and heparin's mechanism of action. So unfractionated heparin binds to antithrombin 3, which enhances the antithrombin inhibition of several coagulation factors, which include factors 12, 11, and 9, 10A, and thrombin itself. Heparin also has some antiplatelet effect, which may lead to heparin-induced thrombocytopenia. Bivalirudin, on the other hand, is a direct thrombin inhibitor. If we compare the characteristics of the two drugs, you'll find that heparin has a half-life of around 1 hour. Bivalirudin is shorter. It has a half-life of 25 minutes. Heparin is metabolized by the reticular endothelial system. Bivalirudin is 80% serum protease and 20% by the kidneys. Heparin binds to plasma protein, but Bivalirudin does not. And that's why it has, Bivalirudin has more of a predictable pharmacokinetics compared to heparin. And then heparin is effective against only fluid phase clotting factors, but Bivalirudin is effective against both fluid phase and clot-bound thrombin. Lastly, one of the major advantages of heparin over Bivalirudin is the presence of an antidote, which is protamine. Bivalirudin, unfortunately, doesn't have an antidote, but it does have a shorter half-life. Both drugs can be used in patients with renal failure, and however, the dosing of Bivalirudin in patients with renal failure can be taxing, giving it shorter half-life. So if we move forward to the trial design, it's an open label randomized controlled trial. It was conducted in 87 clinical centers in 63 different cities in China. Patients of any age presenting with an ST elevation myocardial infarction within 48 hours of symptom onset, undergoing primary PCI, who had not previously received heparin, Bivalirudin, or any fibrinolytic therapy or glycoprotein inhibitors prior to the presentation, were deemed eligible for enrollment. And patients were randomized to either a Bivalirudin arm with post-PCI infusion of a high dose of Bivalirudin or heparin monotherapy. Their inclusion criteria really included patients of any age, patients with STEMI, as I mentioned, that with a symptom onset of less than or equal 48 hours. They had no contraindications to DAPT, and DAPT must have been given prior to the PCI. And the subjects or their legal representative were fully informed of the nature of the study and provided written consent. Their exclusion criteria included patients that are not suitable for primary PCI as judged by the local physician's STEMI, treated by thrombolysis prior to PCI, or any patient who received heparin, Bivalirudin, or glycoprotein within 48 hours before the primary PCI. Any patient with mechanical complications such as VSD, papillary muscle rupture, or acute MR, any known allergy or contraindication to heparin, Bivalirudin, or both clopidogrel and ticagrelor. Patients who were enrolled in other drug or device studies, and patients whom the investigators considered their participation to be inappropriate, and those or the patient that they believed would be non-inherent to the study protocol during the follow-up period, such as those with psychiatric disorders, alcoholism, or drug addiction. So when it comes to the patient flow between February 2019 to April of 2022, a total of 6,000 patients were randomly assigned to either receive Bivalirudin plus a high-dose infusion of Bivalirudin after PCI, or unfractionated heparin monotherapy. The patients in the Bivalirudin arm were bolused with 0.75 milligrams per kg of Bivalirudin, followed by an infusion rate of 1.75 during the PCI. And this infusion was continued for 2 to 4 hours after the PCI. They did give patients an additional bolus of biliverdin if their ACT after 5 minutes of the initial bolus was less than 225 seconds. The patients in the heparin arm received a heparin bolus of 70 units per kg and received an additional bolus if their ACT was less than 225. There was no continuous infusion for heparin. Glycoprotein inhibitors were permitted in both arms only for thrombotic complications during PCI procedures. So none of them were given upstream. Their primary endpoint was all-cause death or BARC type 3 to 5 bleeding at 30 days. Their secondary endpoint is MACE all-cause death, recurrent myocardial infarction, ischemia-driven target vessel revascularization or stroke, stent thrombosis, BARC type 2 to 5, and acquired thrombocytopenia. Looking at the baseline and procedural characteristics, so there was no significant difference in the age between the two cohorts. The majority of the patients were men. Around 23% had diabetes. There's a large number of patients with hypertension, active smoking. Only 6% have prior MI or prior PCI. 11% had prior SOACs in both arms. Their symptom to door time, whether less than 12 hours or more than 12 hours, was not significantly different between the two groups. And then they only used clopidogrel and ticagrelor in this study, so prasugrel wasn't one of the P2Y2 inhibitors, but there was around 33% used clopidogrel and ticagrelor. There was no significant difference. And then they emphasized the need to use transradial, so the majority of the patients underwent transradial PCI. Revascularization was successful in the majority of the patients that did undergo PCI. A very minute number underwent CABG. Thrombus aspiration was comparable in the two groups. And then the TIMI score was a sight read, so per the physician, and it was almost the same in both groups. Their medications and procedures. So the percent of patients that needed additional bolus of their study medication was significantly different in the heparin group compared to the bivalirudin group. Again, so the heparin group received a bolus of heparin, and it wasn't continuous infusion, and only if their ACT was less than 225 did they receive an additional bolus. The bivalirudin, they received a bolus and then continuous infusion, but they didn't need an additional bolus as frequently as the heparin group. Their peak ACT was also significantly different. The heparin group, their peak ACT was 267. In the bivalirudin group, it was 321. And then the number of patients that received glycoprotein inhibitors for procedural complications was also significantly different. Heparin group receiving more glycoprotein protein receptor inhibitors. DAP, a transradial approach, was the same. There was a small number of patients that did need to go in. They use a transfemoral approach. Revascularization, drug-eluting stent implantation, and balloon angioplasty was the same in the two groups. And also the percentage of thrombus aspiration between the two groups was the same. There's also, they also compared, which I didn't include in this table because it's like such a huge table, but they did compare which vessel was revascularized. So, and they found that there was no difference in the number of left mains, LAD, CIRC, RCAs that were revascularized between the two groups. There was also no difference in the number of stents that were placed, the length of the stent, or the procedure time between the two groups. So their primary endpoint, they actually found there was bivalirudin plus post-PCI high infusion reduced the 30-day mortality in patients with STEMI undergoing primary PCI, predominantly with a radial artery access compared with heparin monotherapy, and reduced in their bleeding risk. When they compared their bleeding risk, they also found that BARC 3 to 5 bleeding was also significantly lower in the bivalirudin arm compared to the heparin arm. And then here's a breakdown of the patients who suffered from bleeding complications. So the heparin group had a larger number of patients with non-access related bleeding that was secondary to GI bleeding. And they also required more blood transfusions, and a larger number of patients in the heparin arm had their DAP discontinued within 30 days follow-up compared with the Bivalirudin group. And this included the discontinuation of both aspirin and P2Y12 inhibitors, or both. And the lower rate of bleeding in the Bivalirudin arm might be attributed to its more consistent pharmacokinetics because it doesn't bind to plasma proteins, and maybe because it also does not have any antiplatelet effects. They also compared reinfarction and thrombosis risk, stent thrombosis risk, and found there's no difference. However, the use of Bivalirudin with continuous infusion up to 4 hours post-PCI did show that there was a significant reduction in stent thrombosis. So there's no change and no significant difference in reinfarction, but there was a significant reduction in stent thrombosis. And then for their 30-day outcome, so I mentioned their primary endpoint, there was a significant difference in all-cause death and significant bleeding. There was no difference in reinfarction, ischemia-driven revascularization, stroke. There's a significant difference in stent thrombosis, but BARC bleeding that was of lower tier was not significantly different, and there was no significant difference in acquired thrombocytopenia between the two groups. So the authors conclude that Bivalirudin with a post-PCI high-dose infusion for a median of 3 hours resulted in a relative risk reduction of 1.3, an absolute reduction in the primary 30-day composite endpoints of all-cause mortality and BARC type 3 to 5 bleeding compared with heparin monotherapy. In addition to major bleeding being reduced, all-cause mortality at 30 days was significantly lower in patients treated with Bivalirudin than those treated with heparin, and the stent thrombosis rates within 30 days were lower with Bivalirudin compared with heparin, while the rates of reinfarction, ischemia-driven target vessel revascularization, and strokes were similar in the two regimens. The study strength is, it was a quite large study with 6,000 patients. It was randomized. They had very few exclusion criteria, and they did avoid and address all the pitfalls in prior Bivalirudin studies. So there's been quite a few number of Bivalirudin studies over the years, some of which they compared Bivalirudin with heparin and glycoprotein inhibitors, and there was increased bleeding in the heparin group, and they attributed that to the glycoprotein 2 inhibitors and some other studies where there was a larger number of patients that undergone transfemoral approach, and so that was thought to be the reason for the higher bleeding risk. In this study, they addressed all of that by requiring transradial approach to be the primary. So mostly, the majority of the patients actually underwent transradial approach for their PCI. They also got rid of the glycoprotein inhibitors unless it was for a thrombotic complication. They also, as I mentioned, they restricted the use of glycoprotein inhibitors. One other thing is in prior studies, Bivalirudin was stopped right after the procedure. And so people thought that the higher stent thrombosis risk that was seen in prior studies with Bivalirudin was because of the shorter half-life and it should be infused for longer. And so this study addressed that and made sure to continue the Bivalirudin for 2 to 4 hours after the procedure. And they did find a lower risk of stent thrombosis with that method. Their limitations is it is an open label design. So the physicians, other healthcare providers, and patients were not masked to the treatment assignment. The analysis of secondary endpoints and subgroups were not adjusted for multiple comparisons. So that actually induces a type 1 error, which is false positive findings. So these results should not be used to infer definitive treatment effects. The study also lacks diversity. The patients were only enrolled in centers in China, and a screening log of the number of patients that were screened and was not maintained. So we don't know how many patients were screened, and they didn't include and why. And that's all I have. Thank you for your attention.
All right, thank you, Mariem. Very good review. Seems like a very important study. I mean, the results were pretty astounding, just both in terms of pretty dramatically reduced bleeding and reduced, stent thrombosis and outcomes and mortality improvement. So I guess, so it just seemed like the main wrinkle of this study was a just longer infusion of bivalirudin compared to prior studies. And that seems to, at least if you believe this study, seems to be sort of the magic the magic ingredient for this group of patients.
Yeah, it does seem so. And they mentioned that because, in prior studies, they didn't infuse it for that long, and they stopped it right after the procedure, and they saw an uptick of stent thrombosis. So they took that into account and made sure to continue it. I did try to look into to compare the cost between the two, between heparin and bivalirudin. Obviously, in this study, they're giving bivalirudin as a bolus initially, with an additional bolus if they have a lower ACT score, and then they infuse it throughout the procedure, and then for a median of 3 hours after the procedure, between 2 to 4 hours after the procedure, which is a very long time, compared to heparin being given only as a bolus, with an additional bolus given only if the patient needed it, if their ACT was low. I guess that needs to be looked into.
Yeah, I mean, that was sort of my next question. Other than cost, based on the result of this study, why would you ever give, why would we give heparin to someone, in the cath lab having a STEMI?
I'm not sure really. I think I would like to see another study that would show the same results. And their, analysis of the secondary endpoints, as I mentioned, does introduce type 1 error. So I think that also needs to be taken into account. It is a really interesting study and impactful, that's for sure. But it would be nice to see another study that could replicate the same results with maybe more diversity.
Yeah, I agree with that. Any other questions, comments from the audience?
Stan Sherman, it seems to be fair. You would have to give a second bolus of heparin to compare the two studies, because they really extended the length of the bivalirudin, and you wonder what would have happened if they had extended the length of heparin.
Yeah, that's for sure. Dr. Sherman, I agree with you. And they also don't mention how frequently they check the ACTs. So if you're giving a continuous infusion of bivalirudin, you checked it once, 5 minutes after the initial bolus, and you addressed that, but then the patient's on a continuous bolus, you're less worried that their ACT is going to drop. But if you're only going to check an ACT on a patient that you gave heparin once with no infusion, I don't think that would be comparable. Yeah, so I agree.
Good job, though. Thank you.
Thank you. I was.
Yeah, I guess I was going to ask if any of our interventional colleagues, I'm scrolling through, are there, what is our practice pattern these days in terms of how often are we using bivalirudin in acute coronary cases these days? And if we're not, like, what's the I don't know, what are the limitations to using it, or why some resistance?
Well, I did text Dr. McDaniel this morning, but I was a little too late. But
I'll take that, Robbie, Stan Weir. So our practice patterns changed because, as you know, rail access has really reduced the amount of bleeding issue that we may have. I think that in a setting of acute MI, if there's thrombotic burden, we generally in practice, these are our Emory healthcare facilities. Most of us would give just intracoronary 2B3 inhibitor, which has a much quicker action and platelet suppression. And I think the newer, more potent drugs like the availability of ticagrelor and prasugrel, the action of these drugs still is about 4 hours. So I think to bind that time period, during STEMI, it's not unreasonable to use a 2B3 inhibitor intracoronary. So the other issue with Bivalirudin was a cost issue. And of course, the warnings came up about the pre-procedural stent thrombosis. So in terms of cost, the cost of the system was also fairly high. So some years ago, we decided, to take off Bivalirudin because of the potential stent thrombosis. And yes, it reduced bleeding, but reduced bleeding in the femoral subset. Not so, it really didn't matter if you went radially or not. But since you reduced your bleeding risk by going radially, I think the need for the drug was not there compared to prior studies. Now, obviously, we had trials where post-PCI, the infusion was continued for a few hours after the procedure. But now we don't do that. I think we use heparin if we think there's a need to have potent antiplatelet therapy. We'll give intracoronary tirofiban, but not as a continuous infusion. And if there's a large clot burden, then we'll allow tirofiban to continue for the 18-hour period.
Yeah, sounds good. That was my impression, that it was right, the cost issue plus the early stent thrombosis issue. So, all right.
Awesome. Thanks, Dr. Rob.
Mariem, were you saying something, or did Dr. Rab address it?
No. I'm glad Dr. Rob was on. Thank you.
Any other comments, questions from the group? All right, well, good. Interesting study. We'll see if it has an effect on practice patterns and having people use more Bivalirudin in the acute coronary settings. But I agree, it'd be great to see another study sort of replicate this, because it's pretty stunning, almost a little bit in the too good, maybe edging towards the too good to be true category. But it'd be interesting to see if we see it more in the future.
Yeah.
All right. Well, again, thank you to Mariem. Thank you to Godley for our sort of interventional cardiology, structural cardiology review today. Thanks to everybody, and happy holidays, and we'll see everybody in January.
The preceding program is copyrighted by Emory University.